Imagine your blood pressure is finally under control. Your last reading was good. Your doctor is satisfied. And amlodipine, one of the most widely prescribed heart medications on the planet, is doing exactly what it was designed to do. Now, imagine something you do every single day, quietly working against that medication. Not a rare genetic interaction, not something that requires specialized testing to find, something ordinary, something you very possibly did this week. I've been practicing cardiology for over 2 decades. My name is Dr. Sofia, and I can tell you the complications I see most often with amlodipine are not caused by the drug itself. They are caused by things happening around it, without the patient ever suspecting. Today, I am going to walk you through 5 of those things. But I want you to stay until the end because there is a 6th one I have deliberately left off the main list that sends more of my patients to emergency care than almost anything else on this list combined. I will reveal it after we go through the 5. Do not skip ahead. Let us begin. Factor 1. Grapefruit. I know you have heard this before. Maybe you dismissed it. Please do not dismiss it this time. Your liver contains an enzyme called CYP3A4. Its job is to metabolize amlodipine, to break it down at a controlled, predictable rate so the drug stays at the right concentration in your bloodstream. Your dose was calculated assuming that enzyme is working normally. Grapefruit contains a class of compounds called furanocoumarins. These bind to CYP3A4 and block it. When the enzyme is blocked, amlodipine does not clear your system at the expected rate. It accumulates, and what was a carefully calibrated therapeutic dose starts behaving like something considerably larger. The symptoms of this overdose effect are not subtle. Severe dizziness, pounding headaches, flushing in the face and chest, a racing or irregular heartbeat, and a drop in blood pressure so sharp it can take your balance away, or worse. Here is the detail most people never hear. The enzyme blockade from grapefruit lasts up to 72 hours after a single glass of grapefruit juice. Not a few hours, 3 full days of impaired drug metabolism from one morning drink. So the instruction is straightforward. Remove grapefruit entirely while you are on amlodipine. Not only at the moment you take your tablet. At any time of day, any day of the week. Oranges, lemons, limes, tangerines, all completely fine. Grapefruit is the specific problem. Pomelo and Seville oranges carry a similar risk, so worth noting if those are a regular part of your diet. Think of it this way. A dose that was safe and appropriate for you yesterday becomes unpredictable the moment grapefruit enters the equation. Factor 2. Stopping amlodipine suddenly. And I need you to stay with me here, because this is where the most serious cases I see actually begin. People stop this medication for all sorts of reasons. They feel better and assume the job is done. They run out of tablets and put off the refill for a few days. They read something alarming online. They decide, reasonably enough, that they would like to try managing their blood pressure through diet and exercise alone, which is a conversation absolutely worth having with your doctor, but not a decision to make unilaterally overnight on your own. Here is the physiology. Amlodipine works by relaxing the smooth muscle in your artery walls. Over weeks and months on the medication, your cardiovascular system adapts to that state. The arteries settle into a consistently more open, relaxed baseline. When you remove the drug abruptly, those vessels do not readjust gradually. They can respond with a sudden, powerful contraction, a rebound spasm. This is called rebound hypertension, and it can drive your blood pressure above the level it was at before you ever began treatment. We are not talking about a modest, manageable rise. We are talking about readings that can reach 200 systolic and higher in patients who were previously well controlled on medication. At those levels, the risk of stroke, hypertensive crisis, and acute kidney injury rises significantly. I want to ask you something directly, and this is a genuine question. Have you ever stopped a blood pressure medication on your own without telling your doctor first? Write 1 in the comments if yes, 2 if no. I see this pattern constantly in practice, and understanding how common it actually is matters. If you want to reduce or discontinue amlodipine, that conversation begins with your doctor. A proper tapering schedule gives your vascular system the time it needs to readjust gradually. The process may take several weeks. That is not excessive caution. That is basic cardiovascular safety. Feeling well on this medication is not a signal that you can stop. It may, in fact, mean the medication is working exactly as intended. Factor 3. Prolonged standing without movement. This one almost never comes up during the prescription consultation, and it absolutely should. Amlodipine dilates arteries throughout the body, including those in the lower legs and feet. This is part of how it reduces peripheral vascular resistance and lowers your blood pressure. The mechanism is beneficial, but here is what happens when you stand motionless for an extended period. Gravity pulls blood downward into those dilated vessels. Your calf muscles, which under normal walking and movement act as a venous pump, contracting to push blood back up toward the heart, are not contracting when you stand still. Blood pools in the lower extremities. The visible result is ankle and lower leg swelling that builds progressively the longer you remain on your feet without moving. The result that is more dangerous is what happens when you suddenly sit or lie down after long standing. Blood that pooled in your legs has to redistribute rapidly upward. Blood pressure can drop sharply. This can cause severe dizziness or fainting, sometimes with no warning at all. The solution requires nothing beyond awareness and a small habit. If you know you will be standing for more than 15 to 20 minutes, waiting in a long queue, standing at a reception desk, attending a ceremony, a crowded commute, keep your calf muscles working. Small steps, shifting weight from foot to foot, quiet calf raises, rising up on your toes and lowering slowly back down. These minor contractions are enough to keep the venous pump functioning and blood moving back toward the heart. If movement is genuinely not possible in the situation, try isometric calf contractions, tensing the muscle without visible movement of the foot. Not perfect, but meaningfully helpful. And when you do transition from standing to sitting or lying down, do it deliberately and slowly. Give your circulatory system a few seconds to adjust before you are fully settled. Factor 4. Non-steroidal anti-inflammatory drugs. I will be specific. Ibuprofen, naproxen, diclofenac, aspirin at higher doses. These are extremely common medications. Many are available without a prescription. And that accessibility is exactly why this interaction gets underestimated by patients, and sometimes by providers alike. Here is the mechanism. NSAIDs cause the kidneys to retain sodium and water. More fluid in your circulatory system means higher pressure against the vessel walls. Simultaneously, NSAIDs inhibit a group of signaling compounds called prostaglandins, which are involved in keeping blood vessels dilated. When prostaglandins are suppressed, blood vessels constrict. Amlodipine works in precisely the opposite direction, promoting vasodilation, reducing vascular resistance, supporting the balance of fluid and circulation. These two medications are pharmacologically opposed at a fundamental level. Research examining patients on antihypertensive medications who add regular NSAID use documents. Average systolic pressure increases of 5 to 10 millimeters of mercury. For certain individuals, the effect is considerably larger. In practical terms, this is what it looks like. Your blood pressure control quietly deteriorates over days and weeks. Your readings creep upward. Your doctor adjusts your amlodipine dose. The interaction is never identified because nobody thought to ask about the ibuprofen. For pain management while on amlodipine, the first alternative worth discussing with your doctor is paracetamol, acetaminophen. It does not affect how your kidneys handle sodium, and it does not interfere with vascular prostaglandins. For many common pain types, it is comparably effective. If you genuinely need an NSAID for a specific condition, tell your prescribing doctor that you are taking amlodipine and monitor your blood pressure during that period. Actually measure it. Do not rely on how you feel. Do not assume that over-the-counter means low risk in the context of your specific medication. And now, Factor 5. This is the one that I want you to hear most carefully, because it is the one I see going wrong most frequently in practice. Stopping amlodipine yourself because your ankles are swelling, peripheral edema, ankle and lower leg swelling, is one of the most commonly reported side effects of amlodipine. It affects somewhere between 6 and 12% of patients at standard doses, and a higher proportion at increased doses. If you are on this medication and your ankles swell, you are not alone, not remotely. Here is the mechanism. Amlodipine dilates arteries more effectively than veins. This creates a pressure imbalance at the capillary level. Fluid leaks from the small vessels into the surrounding soft tissue, and it settles predictably at the lowest point of the body. For most people on their feet during the day, that means the ankles. By evening, shoes may not fit, the legs feel heavy, the swelling is visible, and sometimes it becomes embarrassing. So patients stop the medication on their own, quietly, without telling anyone. Here is what I need you to understand clearly. In the vast majority of cases, this swelling does not represent danger to your heart, your kidneys, or your overall circulation. It is a cosmetic and comfort issue, not a signal that something is seriously wrong internally. The fluid is in the soft tissue of your ankles, not building up around your heart or lungs. But stopping amlodipine without medical guidance, that is dangerous, because it brings you directly back to factor number 2, rebound hypertension, a pressure spike that can exceed your pre-treatment levels. If ankle swelling is affecting your quality of life, you have real, established options, but all of them require your doctor's involvement. Dose reduction often significantly decreases or eliminates the edema. Switching to a different calcium channel blocker is another route. A low-dose diuretic specifically targeting the fluid accumulation is a well-supported approach. Your doctor can find the right path for your situation, but finding it requires you to stay in the conversation, not disappear and quietly stop taking your tablets. The swelling is manageable. The uncontrolled pressure surge that follows unguided discontinuation is not. Now, I need to stop here for a moment, because everything I have just described, all 5 factors, it still will not be enough for a significant number of the people watching this video. Not because the information is inaccurate, but because of what happens when these factors do not arrive alone. Let me tell you about a patient I will call Reginald, 71 years old. He had been taking amlodipine for nearly 3 years. Blood pressure well controlled, no major issues. By every standard measure, doing well. Then, over approximately 3 weeks, 3 things happened at the same time. His rheumatologist prescribed ibuprofen for knee arthritis, a reasonable clinical decision for the joint pain he was experiencing. His daughter began bringing grapefruit juice to the house. She had read that it was beneficial for immunity and overall health, and Reginald noticed his ankles were swelling more than usual. He found it embarrassing. He did not mention it at his next appointment. He decided quietly, and without telling anyone, to hold off on his amlodipine for a few days, to see if the swelling improved. His daughter found him on the kitchen floor. His systolic reading when he arrived at the clinic was 217 millimeters of mercury. He was admitted. He spent 4 days as an inpatient while we worked to bring his pressure back under control and trace exactly what had happened. He sustained no permanent damage, and I am genuinely grateful for that. But 4 days of hospitalization, considerable fear for his family, a recovery period that took weeks, all of it entirely and straightforwardly preventable. 3 of these 5 factors simultaneously, each one manageable in isolation. Together, they produced a hypertensive crisis that required hospital care. And now, the 6th factor I mentioned at the very start of this video, the one that sends people to my emergency clinic more often than almost anything else related to this medication. Not telling your other healthcare providers that you are on amlodipine, before dental work, before any elective procedure, before a minor surgery, and especially before anything that involves fasting beforehand. Here is why this matters specifically. Fasting reduces your circulating fluid volume. When you are not taking in fluid, your bloodstream has less to work with. In most people, this reduction is tolerable. In someone whose arteries are already vasodilated by amlodipine, the combination of reduced fluid volume and dilated vessels means the heart has significantly less to pump against, and blood pressure can fall unexpectedly and substantially. Add a local anesthetic, which carries its own cardiovascular effects. Add mild sedation. Add the physiological stress response to even a routine procedure. And now you have a clinical situation your provider did not anticipate and did not prepare for, because they did not know about the amlodipine. The solution takes 5 seconds. Tell every healthcare provider you see, your dentist, your dermatologist, any specialist, the nurse taking your intake form before a procedure, that you are on amlodipine. Write it on every medical history form you fill out. Say it at the beginning of every appointment where anything physical is being done to your body. This information changes how providers prepare. It changes monitoring protocols. It is not over-communication. It is your safety, stated clearly. Do you know someone taking blood pressure medication who has not heard most of what we covered today? There is a very good chance they have not. Share this video with them. The information does not help anyone sitting unread in the description box. And if the ankle swelling side effect is something you are managing or someone you care about is, I have covered what actually works to reduce it without stopping the medication in another video. That link is in the description, and it is worth watching before making any decisions about changing your dose or switching medications. Take care of your cardiovascular system. It works harder and more quietly than most of us ever fully appreciate. 4 story is overnight.